Welcome to the symposium, Ethical, Legal, and Social Issues in Epigenetics, Indigenous, National, and Global Perspectives. The aim of this symposium today is to examine bioethical issues surrounding epigenetics research, including informed consent in the context of uncertainty, the ethics of genetic biobanking, privacy protection for genetic and epigenetic big data, and in particular, a main theme of the symposium is ensuring equitable participation in and benefit from genetic research with a focus on Indigenous people, families, and communities. With that in mind, I'd like to start by acknowledging the traditional owners of the land on which I now stand, the Wurundjeri people of the Kulin Nation, and pay my respects to their elders, past, present, and emerging. I extend that respect to the Indigenous presenters of the symposium and to any other Indigenous people that may be joining us. The symposium has been a long and difficult time in the making, with the initial plans disrupted by COVID, as so many of our plans have been, of course, and the recent and devastating death of one of our organizers, Professor Margaret Kelleher. With that said, I'm so pleased to be able to welcome our speakers who are representing diverse and varied experiences from 5 continents. Our first session examines ethical issues of genetic research for Indigenous communities and the challenges in ensuring ethical distribution of benefit in clinical services for Indigenous people and their families. Questions of tribal sovereignty, Indigenous research capacity, provision of culturally safe care, and Indigenous access to precision medicine will be considered. Our first speaker is Chief Lynn Malerba, the 18th chief of the Mohegan tribe and the first female chief in the tribe's modern history. As well as many other distinguished achievements, she is chairwoman of the Tribal Self-Governance Advisory Committee of the Federal Indian Health Service, a member of the Tribal Advisory Committee for the National Institute of Health, and a member of the Treasury Advisory Committee. I'll now play the pre-recorded presentation. After that, I'll introduce the other 2 speakers and play their presentations as well. And that'll be followed by a discussion and Q&A with the speakers. I'll also let everybody know that this is being recorded. And at any time, you can type your questions or comments into the Q&A. And you can also raise your hand, and during the Q&A session, I'll be able to unmute your mic and you can ask your question of the speakers directly. And with that, I'll begin Chief Malerba's presentation. Please just give me 1 minute to start that video.
Akwai, greetings. My name is Chief Many Hearts Lynn Malerba of the Mohegan Tribe, and I thank the Foundation Brochure, the University of Melbourne, and all the conference organizers for asking me to speak today and kindly inviting me to offer some comments. Songskwa means rock woman or chief in our language, and Matawi Mutahash means many hearts. In the past, I was a critical care nurse and my specialty was cardiology. When I became chief, our medicine woman bestowed this name upon me, stating that you have cared for many hearts in the past, and now you care for our hearts as the chief. And so this is a name that I proudly carry with me forward. I follow in the footsteps of my great-grandfather, Chief Mataga, and my mother, Loretta Roberge, who was on our tribal council and was a tribal leader for over 30 years. So now I'm going to share my screen with you and offer some comments. So I am pleased to offer policy considerations for tribal nations and researchers who are engaged in epigenetic studies. I shared this map with you. This is a map of Connecticut, and I know it's a bit hard to see, but it's in the 1600s, and all of the place names are Indigenous. And that is because that all of these lands were inhabited by the Indigenous people of Connecticut. Once we encountered the immigrants who came to our shores, we lost 90% of our population, and 90% of our lands were taken from us between the early 1600s and the mid 1700s. Now, we have always had continued unbroken government, regardless of the immigrants who came to our shores. And, you know, our diplomatic relations were initially with Europe prior to the formulation of the United States. Our unbroken tribal sovereignty and the exercise of that tribal sovereignty is extremely important to us. And so my remarks today will be in that context. We expect that the United States government and all of the agencies that it controls will engage with us as a sovereign nation and will consult with us as a sovereign nation, and that they will do so within the realm of the trust and treaty obligations of the United States. So this next slide is what happened. Medieval Europe used the doctrine of discovery to assert that the lands in the New World were vacant and available for ownership by the first Christian nation to settle these lands, and that if they did encounter any people here, that they were to live in servitude to the people who then we encountered. This was the basis for the United States, what they believed to be their sovereign right to extinguish the native people's right of occupancy. Now, this photo is a photo of my great-grandfather, Chief Mataga. And one of the things we need to think about here is, are native genetics something for others to lay claim to? You know, does genetic testing inform non-native people about our communities and our cultures? Are we perpetuating cultural harm, which would harm the ability of tribes to exist in the future? Blood quantum is a colonial construct. And, you know, and what it tries to do is to tell tribes who should be a tribal member and who is not allowed to be a tribal member. Well, who gets to decide that? Now, we believe that tribes get to determine their citizenship, their citizens, just as any other nation does. And, you know, we believe that our tribes are not just created by blood relations. They're a very intricate relationship of culture, place, political relations, and social relations. And we engage with the federal government on a nation-to-nation basis. The Indian Reorganization Act in 1934 talked a little bit about that, and they found that there were deplorable conditions in Indian country. And so this act was designed to help reestablish and restore tribes to their previous sovereignty. But what they tried to do with the Bureau of Indian Affairs is to determine for us who would be a tribal citizen and who would not. And so the Commissioner Collier of the Bureau of Indian Affairs said, well, I think it should be 25% blood quantum to be considered an Indian. And the Senate Indian Affairs Committee Chairman Wheeler, said, no, I think it should be 50%. We're trying to get rid of the Indian problem, not create more. So that was the context that the United States was operating under. They really thought that tribes would disappear and the Indian people would disappear, and they no longer have any obligation to us within the trust and treaty obligations. But our Indigenous people ceded almost 100% of the land, 97% of land in the United States to the United States. And today, the riches that the United States receives from that land, it is in the realm of $20 billion a year. And so we believe that the United States needs to live up to its promise to take care of us and to live up to the trust and treaty obligations that they so long ago promised. So as we think about studies and as we think about genetic studies, we need to ensure that all of the agencies that are participating in this respect our tribal sovereignty and that they consult with us. They are required to consult with us via presidential executive orders. And as you see here, Consultation is more than just listening. It's really getting to the point of agreement to really discuss an issue, to understand the policy impacts on Native tribes, and to get to consent from the tribes to agree to a particular policy that an agency wants to follow. Once we agree on a policy and we think that it should be implemented, there still needs to be ongoing evaluation and revision because there could be unintended consequences. And we want to make sure that anything that we agree to is working as agreed upon. So here are some of the policy considerations that we believe are important for genomic studies and Native population. We need to think about, consent. What does consent mean? Does consent of an individual tribal member equal the consent of the tribe? Well, absolutely not. And what are the risks and benefits for tribal communities? There have been some very stigmatizing studies that tribal communities did not even agree to participate in, but instead were undertaken, and then the results were shared, despite the tribes being unaware that those studies had occurred. And a very prominent one was the Havasupai tribe, who participated in genetic studies to address an epidemic of diabetes, and yet only to find that their genetics were used for other studies that were very stigmatizing. So how do we get to data sovereignty? We need to have data use and sharing agreements. Who owns the data? How does the data get published? Do the tribes have an ability to influence how and when and what gets published about them? Who owns the intellectual property rights? And what are the cultural considerations for biosamples? Some tribes believe that biosamples need to be returned to them. Some tribes don't believe that biosamples should even be taken. But best practices are such that some tribes now own their biobanks and they're doing their own studies. I really think that that is something that we can replicate and should be used as best practices. What are the consent issues? And again, I talked a little bit about that. Tribal identification versus self-identification. Is recruitment on and off tribal lands okay? We know that many of our tribal citizens live off reservation, but yet they are still our enrolled citizen. Who gets to determine how recruitment is done? How do we look at incidental re-identification or disclosure with some of the smaller tribes like the Rancherias in the Southwest and some of the very small tribes in the East Coast and on the West Coast? If you have a very small population, it is very likely that there could be some re-identification. And what happens if there is a change of heart in the participant? Is that participant allowed to withdraw from the study? What happens to their biosample once they withdraw? Is there ceremony that should be considered around the return of that biosample or the destruction of that biosample? And what are the risks and benefits to our tribal community? In our tribe, we believe that we would only participate in research that has benefit to us. If there is a question that a researcher is trying to answer that really doesn't benefit to our community or our individuals, there really is no reason for us to do that if it is just, research and academic inquiry. What about plant-based medicines? If there are unique pharmaceuticals that get created based on plant-based medicines, do tribes participate in the economy around that, and are they able to? And some tribes have very discrete practices, discrete healing practices that they would not want disclosed. And they are something that are unique to their tribes and are something that are held within confidence. Research in our eyes, is very important, but we need to make sure that as we think about research that we could take all of these issues into consideration. So what protections are offered for tribal communities? Who determines what studies are approved? Who approves the access to the database? These are all questions that we need to be thinking about. And there has been a lot of work around that. There has been a lot of publications and research done around that. I know that within the United States, there's the Indigenous Data Sovereignty Network that is really looking at these issues and educating our tribal communities about these issues as we think about how we might want to participate in research. Because again, we are not opposed to research. I think that tribes think very long and hard about research, but we also think that research should not be limited to just health. We think about research about cultural practices, land use, archaeological practices, historical and societal research. Those are all very important to us as well. And, who has the intellectual property rights to this research? And I think, we've chatted a little bit about that in the previous slide. So here are some cultural considerations that we should think about. The biobanking and best practices about that. Should every proposed tribal research require tribal researchers that are of every level? And I would argue that the answer to that is yes, particularly with the research access boards. We think that any research that is being proposed on these large genetic databases should have tribal citizens or tribal researchers at every level, so that we can ensure that this research is being done through a cultural lens, and people that are not part of tribal communities perhaps would overlook some of the nuances that are related to our cultural considerations. And that's why we believe it is very important that tribal researchers be very engaged at every level of research. So here is the United Nations Declaration on the Rights of Indigenous People, and I'll give you a moment to take a look at it. But it does talk about control and protection and, making sure that we are protecting our traditional knowledge, but also that we are acting in the best interests of our tribal nations, and that we are the ones that are in charge of that information and how we maintain it, how we control it, and how we develop intellectual properties around our cultural heritage and traditional knowledge and traditional cultural expressions. So we have some very have had some very promising conversations and consultations. The National Institute of Health, NIH, has a tribal health research office, and that office has a tribal advisory committee made of tribal leaders and as well as technical tribal experts. We have worked very hard to educate not only the Tribal Health Research Office, but the entire NIH on what is important to tribal nations and how we should look at research as we move forward. The All of Us work group is a work group that is looking at genetic studies, and the All of Us project wants to enroll 1 million people into this large data set that then can be used for research. And they actually developed a work group comprised of the All of Us researchers, the tribal researchers, and tribal leaders to talk about how best to structure outreach, enrollment, and tribal protections. And one of the things that I think is really important is that we've had ongoing consultations, and once we developed the premises and the philosophy and principles around the research for this project, then NIH went out and consulted with all of the tribal nations, which is exactly what should be happening. Once they did the consultation, held the consultations, then they revised some of their practices and protocols. And I think an important one was that there now is a frame or a way that tribal members who would like to participate in research, as they're signing up, there is one screen that they need to go through that talks a little bit about, does their tribe consent to being identified in tribal research? And if not, they surely can participate because it is their individual right to participate in research, but then they should not identify their tribe of origin unless the tribe expressly and explicitly consents to do so. So that's a way to protect the whole tribal community who perhaps would not want to be participating in this tribal or this research that All of Us is conducting. And we also know that they are looking at adding Native people to the research advisory boards, and that is very important to us. Excuse me. Because we know that that is a way to ensure that there are cultural considerations that are looked at as researchers are developing their protocols and are developing their research proposals. And I just shared this last slide with you. Tribes are in a very unique situation in that we are responsible to our ancestors. They worked hard to ensure that we continue to exist in present day and that we were not considered relics of the past, that we do, in fact, still have a tribal government to engage with the United States government on a government-to-government, nation-to-nation responsibility. And then we are also responsible to those that we have yet to know. So Katap Tontumawish, thank you so very much for allowing me to participate in this lovely presentation and in this wonderful symposium.
Thank you so much for that, Chief Malerba. It was a fantastic presentation and really insightful. I'll introduce the next speaker, the next presentation. Ms. Christy Meiselbach is a proud Gunjit Damara woman and a research assistant in the Evaluation and Implementation Science Unit. She's completed a biomedical degree with honors at RMIT and the University of Melbourne before beginning a medical degree at Deakin. She has a passion for public health and in particular, helping rectify inequities in Aboriginal and Torres Strait Islanders communities' access to various areas of healthcare. And just one moment while I share that video with everybody.
Hello, my name is Christy Meiselbach and I'm a research assistant at the Centre for Health Policy at the University of Melbourne. Welcome to my presentation, Factors Influencing the Use of Familial Cancer Genetic Services for Indigenous Australian Populations. Before beginning my presentation, I would like to acknowledge the land on which we all stand today. Myself standing on Wurundjeri land. I would like to pay my respects to the Wurundjeri elders, past, present, and future. I would also like to pay my respects to my Gunditjmara elders and ancestors, hoping their spirits guide and protect me. In Australia, the mortality rate for Aboriginal and Torres Strait Islander people diagnosed with cancer is 1.4 times higher than for non-Indigenous people, despite having only a slightly higher overall incidence rate. Aboriginal and Torres Strait Islander people diagnosed with cancer also have a lower 5-year survival rate following a cancer diagnosis compared to non-Indigenous Australians. The reasons for this observed difference in mortality are multifaceted and reflect a complex interplay between risk factors such as a relatively higher burden of comorbidity, experiencing more barriers to accessing health services, and less uptake of these when they are available. The result is that overall, Aboriginal and Torres Strait Islander people in Australia are diagnosed at younger ages and with more advanced stages of cancer. While shared environmental risk factors within families are likely to be the most significant contributor, heritable risk-conferring alleles will underlie this observation in a proportion of families, as familial cancers account for 5 to 10% of all cancers. Improved access to cancer screening and surveillance, including the use of clinical genetics and genomic technology to inform prevention, diagnosis, and treatment has the potential to reduce the burden of cancer in Indigenous populations. In particular, given the high rates of cancer diagnosis clustering within families. Geographical, socioeconomic, and cultural barriers experienced by Aboriginal and Torres Strait Islander people are likely to contribute to their underuse of these health services. Now, what is a clinical genetic service? Clinical genetic services provide diagnosis, risk management, patient management advice, and counselling for people and families affected by chromosomal or single gene conditions. They are able to order genetic and genomic testing where deemed appropriate. They do not undertake population-level screening. There are two kinds of services: clinical genetic services and familial cancer clinics, which both offer a different model of care. Both familial cancer clinics and clinical genetic services are equipped to consult with patients who either have a personal or family history of cancer and undertake relevant genetic testing as appropriate to individual cases. Both models of care provide genetic counselling to support patients throughout the testing process, from deciding whether to have the genetic test to receiving results, treatment strategies for surveillance and cancer prevention for those with informative results, and how to inform relatives. FCCs are staffed by multidisciplinary teams, including clinical geneticists, genetic counsellors, medical oncologists, oncology nurses, and specialist surgeons, and are therefore able to cover all aspects of patient care in-house. CGS, on the other hand, stand alone from other aspects of the patient's cancer care or screening management, and are most often accessed by referral from another medical practitioner. Importantly, many people who attend clinical genetic services at most a handful of times, whereas those attending a familial cancer clinic may do so periodically over many years. The aim of the project was to identify the barriers and enablers of attendance to clinical genetic services by Indigenous Australians suffering a personal or family history of cancer. Interviews were conducted with eligible participants. These interviews were then used to identify key barriers and enablers to service attendance and identify common overarching themes. The analysis was used to capture both the experience of the patient and also to inform an appropriate health system response. The four main factors influencing people's experiences were the opportunity to benefit family, availability of follow-up support, appropriate communication and empathetic genetic counselling, experiences of racism, and provision of culturally safe care, including the lack of Indigenous representation in genetic services. Two databanks were used for this analysis: the Better Indigenous Genetic, or BIG, Health Services Project, which investigated the quality, acceptability, and effectiveness of clinical genetic health services for Indigenous Australians, covering 4 delivery models in 3 Australian states or territories, including Western Australia, Queensland, and the Northern Territory, as well as the Kathleen Cunningham Foundation Consortium for Research into Familial breast cancer, or KCONFAB. This is a national resource for familial breast ovarian cancer genetic research, based at Peter MacCallum Cancer Centre in Melbourne. Participants of KCONFAB are recruited by familial cancer clinics across Australia and New Zealand. It includes people with at least one family member who has accessed genetic services for breast and/or ovarian cancer risk assessment and genetic testing. Participants were identified through Northern Territory Genetic Services, Genetic Health Queensland, Genetic Services of Western Australia, and KCONFAB. People who had self-identified as Aboriginal and/or Torres Strait Islander when completing their baseline recruitment for KCONFAB or on intake at one of the genetic services between 2015 to 2018 were invited to participate. Eligible participants were sent an invitation letter, plain language statement, and consent form by post. An opt-out approach was employed, such that invitees who do not want to take part in the project were asked to indicate whether the research team by phone, email, or post. Anyone who had not responded 3 weeks after the invitation was sent a follow-up by phone. Out of 31 eligible participants identified from the KCONFAB database, 16 indicated their interest in participating, and 14 completed interviews. All belong to families with a very strong history of breast and/or ovarian cancer, had attended a genetics clinic, and knew that they carried a clinically significant germline mutation. The interviews allowed participants to describe and discuss their experiences at each step of the patient journey when accessing the clinical genetic service. It is a key principle in Aboriginal and Torres Strait Islander research that the key to improving health services for Aboriginal and Torres Strait Islander peoples requires understanding how services are working from an Aboriginal and Torres Strait Islander perspective, and incorporating this into the design and governance of services. We ensured Aboriginal and Torres Strait Islander research governance throughout multiple aspects of the project, and used an analytical approach designed to privilege Aboriginal and Torres Strait Islander perspectives in all aspects. A number described the decision to access a clinical genetics service was a family decision rather than a personal one. The potential benefits to relatives and future generations, including the opportunity for them to take preventative measures to stay healthy, was the primary motivator for attendance for many people. Among our participants, it was more often a family member than a health practitioner who suggested they consider attending a clinical genetic service. To understand a history of an illness and premature death among relatives, empowering them to make their own decisions about preventative measures and support younger family members to do the same. Participants also described how attending a clinical genetics service served as a driving force for having conversations about the importance of monitoring and preventative measures with their family. Family was also the key source of emotional support for participants. Two enabling factors that emerged from our study were a sense of clarity and support offered by attending a clinical genetic service. Some participants decided to access genetic testing because it offered clarity, while another referenced the psychological benefits, often expressed as a sense of relief because not knowing is worse than knowing. Receiving an informative genetic test could pave the way forward for improved surveillance for cancer prevention and treatment. Being provided specific information or a letter from the geneticist explaining the outcome of their attendance was found to be very useful by patients for sharing with or facilitating an explanation of what their diagnosis meant for other relatives to make sure they were all on the same page. The first barrier we identified was issues with communication around genetic testing, preventative measures, and treatment. The availability of adequate genetic counselling was variable among participant experiences. While several participants described their genetic counsellor as fantastic, others had scarring experiences. One participant described feeling compelled to have life-altering preventative surgery at a young age after just one counselling session, and I don't even think you could call it a counselling session. I was probably there for 10 minutes, the participant described. In some cases, no genetic counselling was available. Another participant expressed a similar sentiment, having little explanation or counselling when being advised that they needed to undergo a major life-changing surgery, including the implications that the treatment would have long term. Some patients felt overwhelmed and that the process and being told that she was a mutation carrier was quite a lot to absorb. Whilst it was explained to some patients how their mutation status may affect other family members, others were given little to no explanation. The second barrier that emerged from the interviews was the impact of inherent racism in the medical community. One participant described, "Sometimes when you see an Aboriginal person coming into a doctor's surgery or wherever, you can see people's faces change. Some medical people look away, and that's not right." Participants expressed the desire to not identify as Aboriginal in their healthcare records, having a mentality of "don't tick that box" for fear of racism, referring to self-identification of Indigenous status on their health records. For Aboriginal persons working in genetic clinics. Participants described a lack of cultural input in their experiences with genetic health services, with one participant explaining that there was no cultural input in their experience and little to no representation of Aboriginal persons or culture at these services. Participants expressed that they felt there was a lack of information about genetic health services among Aboriginal populations. One participant discussed their feelings that Aboriginal communities are unaware of what is available to them in terms of genetic services, specifically in terms of what is available for little to no cost to persons from at-risk families. Our study has identified some key areas in which genetic cancer services should improve in order to deliver more culturally safe and appropriate genetic services to Aboriginal and Torres Strait Islander patients. This includes creating more primary care linkage pathways in order to provide higher quality and coordinated care, addressing discrimination and racism within services through education and training, as well as building the Aboriginal and Torres Strait Islander workforce within the genetic services paradigm. It was clear from the interview analysis that many of the Aboriginal and Torres Strait Islander patients were highly motivated to improve outcomes for their family by undertaking genetic testing. Many found genetic testing to have a positive psychological benefit, as well as empowering them to assess their individual risk and take control of their own clinical journey. By addressing the barriers affecting Aboriginal and Torres Strait Islander peoples at the service level and understanding both motivators to attend and factors facilitating engagement, genetic service providers can begin to make a more positive change to improve engagement of Aboriginal and Torres Strait Islander peoples in genetic testing related to cancer. Strait Islander people are underrepresented at both the clinical genetic service and familial cancer clinics. Based on our findings, targeted action to improve access and engagement among Aboriginal and Torres Strait Islander populations at familial cancer clinics in particular has great potential to achieve better outcomes for Aboriginal people and families affected by cancer. And I would also like to thank all the contributors and funders to this research project.
Thank you for that, Christy. Some really sobering and confronting experiences you've presented there. Thank you so much for that presentation. Our last presenter for the session is Professor Aida Falcon de Vargas, who is a Venezuelan medical doctor who completed her medical studies and postgraduate degree of internal medicine at the Medical Faculty Universidad Central de Venezuela. She obtained her PhD degree in human genetics from the University of London. Among many other achievements, she is the former director of the Medical Genetics Unit at the Hospital Vargas de Caracas, Vargas Medical School, the past president of the Venezuelan Genetic Society, and past president of the Latin American Network of Human Genetics.
Good afternoon. I'm Aida Falcón de Vargas from Caracas, Venezuela, Hospital Vargas de Caracas, Universidad Central de Venezuela. We are talking today about ethical, legal, and social implications of advances in epigenetics and precision medicine, considerations in some Latin American countries. First of all, I am going to share with you some concepts about epigenetics and epigenome. Epigenetics is the study of how your behaviors and environments can cause changes that affect the way your genes work. Unlike genetic changes, epigenetic changes are reversible and do not change your DNA sequence, but they can change how your body reads a DNA sequence. Epigenome generally comprises all epigenetic modifications, DNA modifications such as DNA methylation and histone modification, as well as non-coding RNAs. They are dynamic in nature and their patterns have been observed to change in response to genetic, environmental, and psychosocial factors, and have also been implicated in many human disease states. As Fragile X syndrome, different types of cancers, autoimmune disorders, neurological disorders, and complex genetic diseases as Huntington, Alzheimer, Parkinson diseases, and schizophrenia. Epigenetics occur in different stages of life. Early life, as the fetal alcohol syndrome, middle life, an example is different type of cancer, and late in life, Alzheimer's disease. One of the most common mechanisms is the DNA methylation, which is the cause of fetal alcohol spectrum disorder. It's a group of related conditions that arise from prenatal exposure to maternal consumption of the teratogen ethanol. Fetal alcohol spectrum was described by John and Smith in 1973 and includes several neurodevelopmental disorders described by physical, cognitive, memory, behavioral, and learning difficulties, congenital malformation, deformities, chromosomal abnormalities, and mental and behavioral conditions. Fetal alcoholic spectrum disorders are a group of related conditions that arise from prenatal exposure to maternal consumption of the teratogen ethanol. Fetal alcohol spectrum, Jones and Smith, 1973, includes several neurodevelopmental disorders described, as I say, by physical, cognitive, and different malformations. These issues persist throughout the afflicted child's lifetime, which is often shortened and includes premature onset of chronic disease. Conditions related with epigenetic modifications, DNA methylation in this case. Although fetal alcohol syndrome may not affect all who are prenatally exposed to alcohol, worldwide prevalence is estimated to be approximately 1 to 5%. For the breakdown of fetal alcohol syndrome disorders, demographics within developed countries highlights a major health disparity, whereby groups most affected tend to be of lower income and or belong to a minority. If we talk about social epigenomics, it is a uniquely positioned intersection of population health and precision medicine, allowing us to understand how exposure to social abuse, socioeconomic stress, and environmental, food availability, pollution, green space, stressors modifies the way in which genes are expressed and ultimately alter our risk for disease, and how they contribute to the rising health disparities commonly affected minority communities. Race, ethnicity, or underlying ancestral genetic variation may be associated with risk for particular condition, but may also drive epigenetic alteration not shown that later contribute to disease risk and or pathology. Regardless of genetic factors, social determinants of health in combination with a variety of environmental exposures over time may also contribute to disease risk. Social epigenetics is altered by race and determined by race, ethnicity, social environment, and social experiences, which affect gene function at variation and alter the stage of life. Precision medicine initiative has stirred much hope and some hype since its announcement in 2015. The Ambitions Initiative proposes to accelerate exponentially the adoption of precision medicine, an approach to healthcare that tailors disease diagnosis, treatment, and prevention to individual variability in genes, environment, and lifestyle. Precision medicine is an approach to patient care that allows doctors to select treatment that are most likely to help patients based on a genetic understanding of their disease. Although there have been considerable advances in biomedical research in recent decades, only marginal progress has been made in including underrepresented minorities in studies that will inform the future of precision medicine. Let's talk about the Latin American region. It's the most inequitable in the world, with an average of 25% of the population living in poverty. Health expenditures are low and health systems are fragmented and privatized, with curtailed governmental responsibility and regulation. The main ethical issues identified in genetics in Latin America are inequity in access to genetic services, particularly in prenatal diagnosis, genetic discrimination, and the lack of adherence to internationally accepted requisites of clinical validity and utility for diagnostic and predictive genetic testing. Genomic research has long-standing problems with diversity, especially for indigenous peoples. Indigenous populations face health and socioeconomic inequities and barriers to healthcare that result in poorer health outcomes compared with those of non-indigenous groups. While genomic research has advanced health outcomes in mainstream populations, the dearth of relevant genomic research for minorities and mainly indigenous peoples stand to increase health and healthcare inequities. Indigenous people are underrepresented in genome-wide association studies conducted worldwide. Venezuela, the Venezuelan population is very heterogeneous as a result of the admixture process that occurred between Native Americans, Europeans, and Africans through 5 centuries. Based purely on income, the report says 96% of Venezuelans live in poverty and 70% live in extreme poverty. The composition we are going to see it later on. Several groups started genetic studies in Venezuela in the 50s. Several original clinical descriptions like the ARIA syndrome, Cantu syndrome has been described and published. Hemoglobinopathies has been studied. Disease clusters as Huntington disease in Maracaibo, Venezuela, Laron syndrome in Ecuador, actinic prurigo in Aborigines, Charcot-Levin syndrome, etc., has been studied. American Aborigines and Nature Studies has also been done. 2 countries have national birth defects monitoring programs as Costa Rica and Cuba. The indigenous people in Venezuela, in Latin America is the home of 42 million indigenous people, making up about 8% of the population according to World Bank data. Amerindians or native Venezuelans form about 2% of the total population of Venezuela, although many Venezuelans share some indigenous ancestors. Indigenous people are concentrated in the southern Amazon rainforest, state of Amazonas, where they make up nearly 50% of the population, and in the Andes of the western of Zulia. There are at least 26 indigenous groups in Venezuela, including the Yanomami, Pemons, Warao people, Barigua, Calinas people, Motilons, Bari, Yecuana, Cheguana, and Yaruro. The malaria in Venezuela has been a problem recently. In the years 1950, 1960, Venezuela stood out as the first country in the world that was able to eradicate malaria in large areas of the country and was certified for it. More than 400,000 cases of malaria have occurred during 2017 in Venezuela, most of them in Bolívar and Amazonas state, the largest increase recorded in the world. Hundreds of indigenous children have died due to measles, respiratory diseases, and diarrhea that year, and there is a mortality that is not registered.
Thank you very much, Professor, for that presentation. And with that, I'm very pleased to open up the floor for any questions or comments that people might have for our speakers. Yes, and I'll ask our panelists to turn on their videos as well, please. Lovely to see you all.
Hi, I had a question, if you don't mind me going first.
Of course, please jump in, Evie.
This is actually for Chief Malerba. I was very interested in the point that you raised about individual rights to be in a study versus the tribal identification. And I was wondering what suggestions you have for navigating that if there is a conflict, particularly if the information being connected will incidentally sort of identify the tribe. What would you recommend in that case?
So one of the things that, thank you for that question, I appreciate it. One of the things that we recommend is that individuals check in with their tribes to see what their policy is around genomic studies. And each tribe is probably a little different in terms of where they're at with formal policies. And we need to, again, everyone has a right to participate in any research they choose to. I participated in Nurses Health Study. I've been doing it forever. But I don't identify my tribe because that really isn't salient to that. And so what we're encouraging most tribes to do is to have their own data sovereignty research boards, so that when research is being proposed, that there are people within the tribe that are reviewing the research, working with the researchers to kind of ground them in terms of what might be most important to those tribes. Because again, with the smaller tribes, we we in the Northeast experienced a lot of devastation early on in the United States. And so our tribes are very small and we're all very closely related. In my mom's time, everyone was second or third cousin. So you couldn't marry anyone within the tribe, or you shouldn't. And, you know, so now that we're a little bit bigger, our tribes can marry within, you know, our children can marry within the tribe again, but we're still small enough that, you know, there is that risk for incidental identification. So that's something that we want to work through. So when we've participated in studies recently that had very small numbers of our tribes, what we've asked the researcher to do is to say that the tribe origin was a Northeast Woodlands tribe or New England Woodlands tribe, as opposed to just Mohegan. And so that's a way to protect all of our Mohegan people, but still to gain good information through research. Thank you for the question.
Thank you very much. And obviously, thank you to all the speakers. I should have said that first. And on behalf of everyone here, but also everyone that's going to be listening on the recording as well. It's fantastic to hear these perspectives.
Thank you. And I would like to say thank you to my fellow panelists. Your presentations were just terrific. Thank you. Muted.
Hello, I'm Claire. I've got a question for Chrissy. Great presentation, and I think that's quite. Yep. I think your data shows that there still is a lot of work to do in the cancer genomic space in Australia. I'm interested to know if you interviewed any clinicians or like genetic. I guess, did you get the perspective from the service providers that they were unsure about how to communicate or navigate the pathways for clinical genetic testing in familial cancer for Aboriginal and Torres Strait Islander patients? Like, what was their perspectives on how their engagement with those kinds of patients?
You're on mute.
There we go. There we go. So my little, I guess, research was like a topic of our bigger study on genetic services in general, and included like range of different genetic diseases and interviews with various members of the clinical genetic service like levels, including clinicians, patients, nurses, etc. In my particular sort of subset of that, we haven't looked over any interviews from the clinical geneticists or staff. I think that would actually be a really good area to look at. We just have focused on the familial cancer patients, just because there has been research into Aboriginal and Torres Strait Islander engagement with cancer services, but there's little information on their engagement with genetic cancer services or genetic services in general. So we sort of wanted to dive into their experience, their stories, and what their experience was when accessing those services. But I definitely think that in the future, going forward, we could be more specific when talking to the clinical geneticists and the physicians about their experiences dealing with families and patients who do have cancers, and especially cancers that are hereditary, and so on. So yes, but there is a little bit of research into, I guess, how clinicians have felt when dealing with Aboriginal and Torres Strait Islander patients. And I guess one of the things that have been brought up is that Aboriginal and Torres Strait Islanders we don't necessarily have, we're quite non-nuclear with our family structure. We're not necessarily just immediate family. We have aunties, uncles, sisters, brothers, everyone is sort of included, and we're a quite tight-knit community. And so sometimes when patients have gone in to get their genetic counselling or get a diagnosis, they've wanted to take quite a few family members in, and clinicians have said that because they don't quite understand that family structure, they've not really known how to address those families. And, some Indigenous patients have felt that, the physicians have felt that bringing in, a few family members has been like a burden and an inconvenience to the clinician. And so I definitely think that there needs to be more education to physicians and, staff around those kind of cultural aspects, which, including family and extended family in those discussions, and that they're going to get a much better result, and the family is going to be able to better understand their diagnosis, especially with hereditary diseases. It's not, especially in the study, we found that, it doesn't just affect the main driving force for people going and getting these tests were to be able to relay that to their family. So I definitely think that that's something that, needs to be looked into more. So, yeah. But thank you for your question.
Absolutely. Thank you so much for that, Christy. I had a question for Professor Falcon. Professor, you mentioned that Latin America is one of the most inequitable, or the most inequitable region in the world. And at the same time, as you note, one of the dangers of genomic research is that it carries the risk of exacerbating health disparities. So can you talk a bit about how that might play out within Latin America, and what might be done to ensure equitable health benefit from genomic research and services? So you're on mute, Professor.
Yes. We have been working a lot in Latin America, in all Latin American regions, really there are a lot of differences between all the countries. And in some countries, as Brazil, Argentina, and perhaps a little bit of Ecuador, they have a more better developed genetic services, but the problem is that most of the genetic services are private, and mainly with prenatal genetic services, and are not affordable for most of the people. Of course, there are just a very few and attached to some universities. And the people, the minorities, they don't have, they can afford to go to genetic services. So the problem is that if we talk about epigenetics, many of the diseases that are related with poverty, because of many people in many countries, in Venezuela is one of them, most of the very poor people are starving, the nutrition is very bad, and folic acid and all of those special things, and the needs, the special needs are related with bad, very bad health conditions and poverty. For instance, we have been in touch with UNESCO, WHO, and many other organizations, trying to get involved in genetic services and for most of our people. But it's very difficult because most of them are related to public policies and government's policies. And that's one of the main things that are we are facing in our countries.
Thank you so much.
Okay.
We have a question that's come in from Q&A, and this is also for you, Professor Falcon. And Philippa is asking, prenatal screening and testing has also been identified as one of the most significant gaps in access to clinical genetics among Australian Indigenous populations. Despite research showing these women wish to be included, although awareness of what is available is low, usually because clinicians don't talk to their Indigenous patients about it. Philippa is asking, is there any knowledge about Indigenous women's perspectives on this in Latin America, on prenatal screening and testing?
No. I don't have, I don't think we are, most of our, I'm sure, most of our Indigenous people don't reach genetic clinics. They don't go to genetic services, and they don't have prenatal diagnosis. Even we are having a lot of problems in Maracaibo with the Huntington disease, because we have the greatest focus, the greatest kindreds in the world, in Zulia state. And one of the problems is that we are facing the lack of prenatal diagnosis, of course. And it's a problem because even if you do the study of the gene, you cannot be sure if the fetus is going to be affected or not. But most of our Indigenous people don't access to prenatal diagnosis in our country.
Thank you, Professor. I also had a question for Chief Meleba. And Chief Meleba, you've spoken a bit about the NIH consultation processes that have been initiated, which are, fantastic. And you've also talked a bit about some of the changes that have been brought about in protocols because of them. Of course, one of the themes of the symposium, and one of the things that we know generally, is the underrepresentation of Indigenous peoples in genomic research. And I was wondering if those initiatives from the NIH have been effective or successful in addressing this.
They're really at the beginning of their large All of Us project, which is they're looking to enroll 1 million people into the All of Us project, into a large database with which to do research. And so they're just starting that rollout with the Indigenous people. Because what we asked was for them to hold on that until we could resolve some of our concerns. So now they have a set of guiding principles that they're using, which we're really pleased with. And then sorry, I was muted. They also have a guiding document now that helps, say, a non-native researcher engage with Indigenous communities. So we have yet to see the impact of that, but we, again, are now able to have Indigenous people on the Research Access Board and have people throughout. They just finished up the consultation with all of the tribal nations throughout the United States. And so we know that what we will do is probably 6 months from now, revisit that topic with the NIH and see how it's going, and see what enrollment looks like, see if the process has worked well, and we'll go from there. What I'm really pleased, though, is that this NIH work group has a lot of Indigenous researchers on the work group, as well as tribal leaders like myself. I'm not a researcher by my career, although I did spend time in healthcare. I do more policy work now. So it's a good blend of people that are on this advisory committee. So we're pleased with how it has worked so far, but it did delay their rollout with Indigenous people for about a year. So I think that that's a real commitment on their part.
Sorry, you would think that after 18 months of using Zoom, I would learn Zoom.
No, we're all the same.
To follow on from that, as I said, it's a great initiative, and I'm wondering, you know, as one of the themes of the symposium is looking at how we can ensure equitable benefit from genomic research for Indigenous populations. Can you talk a little bit about, I guess, the extent to which there is the possibility of learning, of Indigenous peoples learning from each other, and what needs to be in place for that to happen?
I think we have a real opportunity. One of the highlights, I think, in the United States is the South Central Alaska Biobank with all of their Indigenous researchers. I'm learning from them greatly because I think that they really are leading the way for us. And, you know, each region is going to experience their own unique needs. And I was fascinated by your discussion on epigenetics, because we think about what has happened to our Indigenous people in the United States. Although our Indigenous people occupy 3% of the lands, 25% of the Superfund sites are on Indigenous lands. So uranium mines and are you know, just terrible Superfund sites. So we know that our epigenetics have changed, not just because of the toxins in our environment, but also because we were relocated. Many of us were relocated from our traditional lands. So our traditional medicines, our traditional foods were all taken from us. And we know that that has really impacted us. And I believe that the field of epigenetics is going to make a huge difference in our health. And that will be related to genomic studies. One of my friends, Chief Beverly Cook, who is also on the National Institute of Health Advisory Committee, says the first environment that our children experience is the prenatal environment. So we need to make sure our mothers are healthy, because that's the only way subsequent generations are going to be healthy as well. So the work that everyone is doing around that, I think, is very, very important to our ability to exist as a people.
Thank you so much, Chief. And I have about 100 other questions, but I will pause to see if there's any from the attendees.
Hello. I might try and mute myself.
Sorry, I'm sitting next to Angela. I sound echoing, but I've got another question for Chief Minerva. I guess in light of the other two presentations regarding access to clinical genetic services, are you able to comment on how the US sort of delivers genetic health services to American Indian and Alaska Native tribes, and the effectiveness of those models?
I'm sorry, I missed some of that question.
No, that's okay. I guess given the themes of the other two presentations about access to services and the types of models that are used with Indigenous populations there, are you able to comment on, I guess, the models used in the US and how those models, I guess, accommodate for your Indigenous populations in the US?
Sure. And thank you for that question. We have a very unique way of delivering care to our Indigenous population. As you know, we have a service called the Indian Health Service. And in the old days, it was a very paternalistic system. They would come into your community because it was based on treaty rights. And so they would come into your community and deliver the care that they thought you needed. And it wasn't a great model of care. And interestingly, the first time we had any sort of Indian health services was during the Civil War, because they didn't want the tribes to give the soldiers communicable diseases, which I thought was pretty ironic, right? So Indian Health Services is very poorly funded. The average spend in the United States for, just a US citizen is about $9,000 per person. The average spend for Indian Health Services is $3,600. So you can imagine there's this huge disparity. But what we have done is tribes have taken over the treaty. They have into the role of the federal government in delivering the care under tribal self-governance. And so under that, tribes are designing and developing the programs that they think are important to their communities, as opposed to Indian Health Services deciding for them. And that has been very successful, and tribes have been creating health systems that will allow them to be self-sustaining and supplementing the amount of funding that Indian Health Services provides. But interestingly, within the federal budget in the United States, Veterans Health, Medicare, which is our elder services, and Medicaid is all on the mandatory side of the budget, but Indian Health Services on the discretionary side of the budget, meaning it could go away. And it never keeps pace with inflation, technology, population growth. And so despite the fact that our Indigenous people are the only people that have treaty rights to healthcare in the United States, it has been woefully provided to us. So tribes have taken it upon themselves to really be more holistic and think about the social determinants of health, because you can't just silo health into, I'm going to worry about your blood pressure. You have to really think about what creates health in your community. And I think tribes are working hard to address just those things. So whether it's childcare, employment, clean water, a good environment, tribes are working hard to be creative, but we are still trying to hold the United States feet to the fire in terms of delivering on their trust and treaty obligations. As I said, the United States was founded on land that was taken from our Indigenous people, and and it was agreed upon by the tribes to say, all right, well, okay, this is inevitable. So, but in return, you will provide certain services to us, and we are going to hold them accountable for that. Thank you.
Thank you so much, Chief Malerba. We have another question for you coming from Jeffrey Craig. Thank you so much, Jeff. And Jeff asks, you mentioned that we know our epigenetics have changed. And to what extent has the idea of epigenetics been raised in your community?
It is raised. And, when we think about some of the things that we're working on, there is a special diabetes project for Indians in the United States. And we have made significant gains in reducing the amount of diabetes and really treating diabetes much more aggressively, beginning with our children and moving on forward. So we recognize that there are certain illnesses that we are experiencing because there was a change in epigenetics. And you also have to wonder about some of the intergenerational depression due to relocation, due to the boarding schools, children being taken from their families, how that has impacted us both physically as well as in our behavioral health status. Imagine being taken from your family at age 4, never to return until you're 18 years old. How do you learn how to be a parent if you've never been parented yourself? You are taken from your community, you're taken from all of the things that you hold dear. How do you even reacclimate back into that community? So I think we are at the tip of understanding, I think, how our epigenetics have changed. Thank you.
Thank you, Chief. And Ms. Meiselbach, we have a question for you as well. And the attendee says, you've talked about the lack of cultural input at services. What kind of things could be done to improve cultural safety in cancer genetics clinics? And how would you expect this to improve differences in access and outcomes?
Yep, so there's quite a few ways that genetic services can sort of increase that cultural input. Obviously, increasing the Aboriginal workforce, like sort of on various levels, with like staff liaison officers and things like that. and the use of workshops, training and education around culture, traditions, language, the use of translators. Most physicians don't even know that, there are translators available for Indigenous populations, because there is about, there's quite a high percentage of, Indigenous populations in those remote and rural areas where English isn't a first language. And they go into these health services and they don't understand the language well, and they end up leaving confused and not with the answers they want. And most of the time they don't book any follow-up. They, end it there because they haven't been attended to in, like a very holistic way, and haven't had that good communication. So by, if they are able to increase that education, and increase the, Aboriginal representation in these genetic services, most likely, or what has been seen in, other areas of health, is that they end up having a higher number of engagement from Aboriginal and Torres Strait Islander people, and that you get an increase in that follow-up care. So yeah, I think it's really important to really just get that cultural training and input, from the communities, so that, Aboriginal people are being more well represented within those services.
Thank you so much, Ms. Meiselbach. And I think that pretty much we're just about out of time, unless somebody has one more question, but I'm not seeing any coming through at the moment. So I might thank our presenters so much for their really interesting and insightful presentations, and the conversation and discussion as well. So we're going to have half an hour, and then our second set of presenters are going to be up. So I hope that I'll see most of you in another half hour. Thank you so much, all of you.